build smaller hospitals and just have many of them at different in our area. And when I went there, I was struck by the fact it costs only about $78 million. It took a year and a half to build. And I remember walking in and I was like telling myself, why we cannot have something like this in Libya, subhanAllah. So these are the pictures from inside the hospital, how the hospitals look like here. And moving forward to talk about the COVID-19, we have very limited experience, not here in the United States, but the entire world. If we go over the timeline, and you'll see that it started in China in December of 2019, and then on December 31st of last year, the WHO said that there is mysterious pneumonia sickening dozens in China. On January 11th, China reported the first confirmed case was detected in the United States, although there was some reports came later that probably it existed even before that date. On February 11th, the novel coronavirus was renamed to COVID-19, which is known now. COVID meaning coronavirus disease. 19 is for the year 2019. And February 29th, the first death was reported in the United States. On March 4th was the first patient was admitted to our hospital. The patient that I talked to you about from New Jersey, the entire family got the disease. Unfortunately, they lost him, the sister, and the mother from the virus. As of today, more than 1.1 million positive cases and patients in the United States, and 66,000 deaths. And in the state of Pennsylvania, there was 49,267 tested positive and 2,444 deaths. And today, in the last 24 hours, there was 962 new cases tested positive, and there was 26 new deaths in Pennsylvania. As of today, we have 2,653 patients hospitalized, 552 of them on ventilators, and 19 of those are on Ecmo machines. So in general, 80% of the individuals infected with the virus are asymptomatic or develop a very mild disease, and they do not need to be hospitalized. That's the good news. However, 20% develop severe disease requiring hospitalization, and approximately 5 to 8% of the total infected population will become critically ill. The clinical features of these patients is profound acute hypoxemic respiratory failure. Patients, they will be hypoxic, however, they don't feel short of breath, or they do not have dyspnea. Hypercapnia is not common except in patients with pre-existing conditions like chronic lung disease with hypercapnia. And the breath, however, they are hypoxic and requiring oxygen supplement. However, once they develop dyspnea, they can progress very quickly to develop full-blown ARDS in a matter of 1 to 5 days from the onset of dyspnea. Fever tend to wax and wane during the ICU admission, and the need for mechanical ventilation in those critically ill patients has been high-ranging from 42 to 100%. And this is a wide range, and the reason for it, because these are the different reports from the different institutions. There is other clinical features and complications that we have noticed in such patients, including acute kidney injury, The majority of them are mild and they recover. Very uncommonly, they end up needing to be on dialysis or continuous dialysis. Elevated liver enzymes are noticed in almost all of the patients with elevation of AST and ALT. Some of the patients develop cardiac complications, including myocarditis, pericarditis, and pericardial effusion. In the early days of having these cases or the COVID patients in the state of Washington, there was reports of patients who develop acute hypoxic respiratory failure. They will go through the course of the disease, they recover and they get much better. And then they have sudden cardiac arrest, whether it's systole or ventricular fibrillation. The majority of those patients, unfortunately, didn't make it and died. Shock and multi-organ failure are less when compared to non-COVID-19 related ARDS. Actually, the majority of the patients, they have only one single organ failure, which is the lungs, and most of the vasoactive medications, vasopressors use is needed to treat hypotension caused by the sedatives after intubation. It's different in these patients that act different in terms of the need for sedation after intubation, and the majority of the patients required to be sedated with multiple agents compared to non-COVID patients. It is really not clear why they chew through a lot of sedatives. Secondary bacterial pneumonia, mostly caused by Staphylococcus aureus and Pseudomonas aeruginosa, has been noticed, and encephalopathy, metabolic encephalopathy and delirium occurs in those patients. We have recognized that these patients, they have issues with inflammatory markers and elevated D-dimers, but COVID coagulopathy is more and more being recognized as a common finding, and some patients develop abnormal coagulation profiles. Others develop thrombosis. When we check labs on those patients, the majority of the patients, they have normal white blood cells, but they have lymphopenia. They do have elevated D-dimer, as we mentioned in the previous slide. Lactate dehydrogenase is elevated, ferritin, fibrinogen, and C-reactive protein. We do also check procalcitonin to distinguish these patients from the patients with bacterial infections and abnormal PFTs, as stated earlier. The reason we check for the ferritin and the CBC is because some of early reports suggested that these patients may progress to develop HLH. Unfortunately, we have not seen any of those patients. When you do imaging for these patients, the findings are consistent with ground glass opacitys with or without consolidation. It's seen on the chest x-rays in the majority of the patients, and also when patients, they have CT scan of the chest. Pleural effusions are very uncommon in those patients. I have to make a point here that CT chest was used as a diagnostic tool in China. However, in the United States, it is really discouraged to have CTs for this purpose as a diagnostic tool. And the reason for that is the risk of transmitting the virus is very high. It requires a lot of cleaning or decontamination of the CT room, as well as probably the risk of exposing the other staff. But there is different ways of diagnosing these patients. If we look at examples of the chest x-rays, these are patients at variable stages with COVID-19 pneumonia. This is a CT cuts from similar patients, and the finding here is the majority of the patients, they have peripheral opacities rather than central. Before we started treating these patients, we went through a roller coaster ride, if you will, and because we had no clue how to manage these patients. We relied on the experience from China as well as Europe, especially Italy and Spain. And we, in our network, our group, met together and we put an algorithm that we have been refining and updating almost every week, just so we will be able to manage better as we learn on the go. So what we did, we divided the disease based on the severity of symptoms and oxygenation into 4 stages: mild, moderate, severe, and very severe. If the patient has viral symptoms but no shortness of breath and requiring oxygen less than 4 liters, it's mild. And if they have shortness of breath with the viral symptoms and they require oxygen more than 4 liters or 4 liters and more at rest, then that's moderate. If they require more than 10 liters of oxygen and they have severe shortness of breath, that's severe. And if they end up requiring intubation, that's very severe. And the reason we divided it because we developed an algorithm of treating these patients based on the severity of the disease. So what we made recommendations because we were overwhelmed with the number of patients coming to the hospital. So the pulmonary critical care team, as well as the infectious disease team, will not be able to see every patient. So those algorithms, we distribute them to the internists and hospitalists to be able to manage the patients on their own with some guidance. And we were all available to them for questions to help with the management. So the mild patients, what we recommended is to do blood type, CBC with glucose daily, as well as an EKG to measure the QTC interval. Also check serum interleukin-6 at baseline, and then we recommended to start the patient on vitamin D supplement, hydroxychloroquine, 800 milligram on the first day, and then 200 milligram every 12 hours from day 2 to 7. In those cases, there was no need to consult any service, and the patients may require or need antibiotics based on their risk. Now, I have to make a disclosure here that none of this treatment is evidence-based, meaning there was no randomized controlled studies that helped us to develop this algorithm. This is all like, we worked hard to see what happened in China and Europe and come up with the best plan for our patients. So what I'm telling you is how we are treating patients in our network, not necessarily somewhere else. So there might be variability of what you hear. For the moderate patients, we do CBC and CMP daily. The reason for that is we would like to trend the white blood cells and the lymphopenia, as well as check the liver enzymes and the electrolytes on those patients. EKG baseline, and then have the patient on a monitor just to monitor the QTC interval. We have patients that had prolonged QTC, hydroxychloroquine, because it prolongs the QTC and predisposes the patient to arrhythmia. Initially, we were using both azithromycin and hydroxychloroquine. Both of them can impact the QTC. So that's the reason why we had the patients on a monitor. Also, we had patients, we discontinued those medications when the QTC was prolonged. Also, we recommend to check cardiac enzymes, proBNP, CB, and also to check the IL-6 at baseline. We recommended all patients when they have moderate disease to receive ceftriaxone and doxycycline. And as I said earlier, in the beginning, we used azithromycin, this to cover atypical bacterial infections. and then to trend procalcitonin. And if the procalcitonin times 2 apart from each other 24 hours is negative, then we discontinue the antibiotics. And the reason for this, we noticed that some of the patients, they had also bacterial pneumonia, and they got worse by missing the initial treatment. Hydroxychloroquine for those patients, similar to the previous mild cases. And then we check the ferritin. If it's more than 600 and the CRP or C-reactive protein is more than 90, then what we consider doing in these patients is to start them on steroids, methylprednisolone, 0.1 to 1 milligram per kilogram intravenously every day. So we monitored the patient's symptoms as well as the inflammatory markers. And if the patient did not get better and the inflammatory markers remained the same or kept rising while they are on the steroids, we stopped the steroids. These patients also, we considered starting them on systemic anticoagulation, and we will go over who to anticoagulate in the next few slides. These patients also received vitamin D, vitamin C, and zinc supplements. And the reason for those is just from the previous experience and some studies that those supplements may tame down the cytokine storm that is these patients having. And also atorvastatin, which is also as anti-inflammatory in this case, not necessarily to lower the lipids. What we did also, we encouraged patients to self-prone, so they lay down on their stomach. And we were successful in convincing the patients by showing them the O2 saturation while they are on their back, and then when they self-prone, they noticed that their oxygenation improved, so they were very motivated to do that themselves. And what did that led to improvement in their oxygenation and bought us time, so they will avoid intubation. And again, these patients, they don't need to be seen by infectious diseases, but the primary team need to notify the pulmonary and critical care team in those cases. If the patient is severe with the oxygen requirement of 10 liters per minute or more, then similar to the management of the moderate cases. In addition, we check hepatitis panel as well as rabid HIV. And then after 24 hours of steroid therapy, and if there is no improvement, we consider giving the patients tocilizumab, which is anti-IL-6. The tocilizumab is given in a dose of 400 milligrams once, and then you reassess the patient in 12 hours. And if there is no improvement, you may consider giving them the second dose of 400 milligrams. Again, we'll talk about the systemic anticoagulation later. There should be a consideration for convalescent plasma therapy in such patients. In my opinion, these interventions, whether it's the plasma as well as the tocilizumab, work better in the early stage of the disease rather than later on. And the reason, because it seems that the virus infects the cells and then the body reacts to it, which will lead to stimulation of a lot of inflammatory mediators, and will be released, leading to this cytokine storm, and that's what causes a lot of the dysfunction and the symptoms. So if you can tame the cytokine storm by these agents early on regarding the tocilizumab, or by giving the plasma early on when the antibodies can fight the virus load when the viremia is at its peak, then probably you will have a much better response. In the very severe patients who are intubated, we do similar management to the previous severe cases, and after intubation, what we have noticed that those patients develop thick tenacious secretions, especially in the small airways, and cause impaction or plugging of those airways, leading to high peak airway pressures. And in China, they used mucomist or N-acetylcysteine. However, in our institution, we had issues with it because it kept on blocking the filters, which led to breaking the circuit of the ventilator, and that has increased the risk of exposure to the staff in the room when you break the ventilator risk on a patient with COVID-19. But instead of using the N-acetylcysteine, we used levoalbuterol with hypertonic saline, and that would be just to liquefy those thick secretions. What we did also, I have to say that initially we took the recommendations from China and Europe by doing early intubation and early proning with high PEEP and low tidal volumes. However, as we learned from our own experience, that patients not necessarily need to be intubated, and we were dragging our feet in some of the patients while we put them on different modalities of oxygen supplement. And what that led to, we were able to avoid intubation and such, and they are on a PEEP more than 12 or equal to 12, and FiO2 more than 60%, and their PF ratio is less than 150, we do early proning. If no improvement, what we do is add inhaled ibuprostanol. There is different brands known for it, Flolan or Velitri, which is used, and you will and these patients will have continuous inhaled ibuprostanol through the ventilator circuit. And ECMO is used in very selected cases. We have not had any patients in our institution on ECMO, and from the previous studies done in ARDS patients, ECMO has not been proven to be superior to conventional treatment of ARDS patients with low tidal volume and proning. And I think Dr. Muhyiddin Maitig will elaborate more on that. Then the last thing is to consider using the remdesivir, which is the antiviral medication that initially designed to treat the Ebola virus. However, it did not do as good, but the dose for the remdesivir is 200 milligrams on day 1 and 100 milligrams IV from days 2 to 10. Now, it was not available except through compassionate use through the company, which is called Gilead. And you have to apply and fill out a form with the patient information, and then they will go through approval process. In our institutions, we were able to get only 5 patients approved. So it is not like any other antiviral medications available, and I don't think it is still, I don't think it's available in general. And I think they probably are gearing up towards a mass production of this medicine to be available not only in the United States, but also in the other countries in the world. So we talked about the self-proning and the concept it helps patients lie on their belly, and that would be for a period of 12 to 18 hours a day, and that we remind the patient to just lay down on their side, either side, or sit up in bed and lie on their stomach. And what's the benefit of this? It will recruit lung tissue, improve secretions clearance, and also improves the perfusion to the more healthy alveoli. In general, the disease is in the posterior aspect of the lungs, and when people are laying on their back, by gravity, perfusion goes more to the diseased area, and that leads to the hypoxia. If you have them on their bellies, then they will have better perfusion to the anterior, more healthy alveoli, and the oxygenation improve. And the result of this, it decreases intubation in such acute hypoxic respiratory failure patients. So these are like cartoons of how to prone these patients. Of course, you don't put their face on the pillow, but just you can adjust And what we did, we had like the beds adjusted so the head of the bed would be facing the TV, so they were laying on their beds and watching TV. Anyway, most of the patients are on their phones or iPads, so they not necessarily care much about TVs. Also, they will be on each side and just to try to stay in those positions for the most of the day, between 12 and 18 hours. Regarding our guidelines for anticoagulation at St. Luke's, what we did, we had them divided into different groups. Group A, which is full intensity, and those patients with confirmed deep venous thrombosis or acute pulmonary embolism or other reason for full anticoagulation. Or these patients, they may have high suspicion for venothromboembolic disease, but we cannot confirm that disease for various reasons. Either the patient is unstable for transportation, or they have acute kidney disease and their creatinine is elevated and you cannot give them intravenous contrast. So in those patients, we treated them with enoxaparin 1 milligram per kilogram to 12 hours as a first line, or used unfractionated heparin following the venothromboembolic protocol that we have in our institution if these patients, they have renal failure. I have to mention also, because there was a question yesterday about thrombolytic therapy, that there is no specific role for thrombolytic therapy or recommendation regarding thrombolytic therapy in COVID-19 patients. However, you may use it if there is any evidence of overwhelming clotting in such patients. There was 2 examples. One patient had COVID-19, got better. He was discharged on one of the oral anticoagulation agents, and he returned with deep venous thrombosis, and D-dimer was elevated. So he was switched over to heparin, and then he was placed on enoxaparin and was discharged home. The majority of the pulmonary embolism that we found in our patients, they are more what it seems to be thrombosis rather than embolic disease, because these thrombi were found, or the filling defects on the CT angio were found in the peripheral veins rather than in the more proximal veins. I have to make a point that the virus has a predilection to infect also endothelial cells and cause damage, and probably that's the reason why you have thrombosis not only in the veins but also in the arteries as well. Group B is intermediate intensity, which is patients with a D-dimer more than 2.5. Now, this cutoff is really arbitrary, not necessarily based on any evidence. We use different cut numbers, 2.5, 5, or 10, but this is just based on our institution. We had to come up with a number so we can be a little bit more aggressive in treating these patients, as we had patients got treated, got better, went home, returned with acute pulmonary embolism or other thrombotic disease. In those patients, we treat them either with enoxaparin or unfractionated heparin, and then transition them to oral anticoagulation. The last group is the ones who have lower intensity, and what we did thromboembolic prophylaxis doses of either enoxaparin or heparin subcutaneous, and the dose is based on their BMI. Moving forward to talk about how we are ventilating these patients, we came up with an algorithm, as you can see on the screen, for the patients who have acute hypoxic respiratory failure. Our general goal is to achieve a SpO2 of more than 90%. What we used initially as standard nasal cannula, and we increased the the oxygen flow to achieve that goal. But if we fail to do that through the regular nasal cannula, which can go up to about 6 liters, we transition the patients either to mid-flow, which is a different device to supply or supplement oxygen via a bigger nasal cannula, and this is going through a smaller or a different canister of moisture, so that the air will be moisturized before it goes to the patient's nostrils, or use high flow oxygen. What we did, we kind of had a concern about high flow nasal cannula because of increasing aerosolization. And what I mean by that, the risk of transmitting the virus is increased when there is aerosolization. The high flow oxygen, and I will show you a few examples in the next slides, it has two components. It's the flow, you can go up to 60 liters per minute, which also can have a PEEP effect on the patient and decreases the patient work of breathing. And also you can have a mixer which will increase the FiO2, and that would help the oxygenation. So we were liberal in terms of giving the patient oxygen up to 100%, limiting the flow to 30 liters, which we felt that would be less risk for aerosolization. If the patient failed that, we recommended not to use BiPAP or CPAP in those patients because of the high risk of leaks from the mask and aerosolization, which will increase the exposure to the staff working with the patient. And I have to say, alhamdulillah, we have not had any of our staff infected from the virus, despite the fact we had more than 800 patients admitted to our hospitals. The invasive, we'll talk about it in a few slides down, and this is how the high flow oxygen work. The left is, you see that the demand for oxygen by the patient will get just a little bit of what he needs through the regular nasal cannula. However, if you give them high flow oxygen, then they will meet their demand and they will feel remarkably better. This is a system called OptiFlow, and it has a mixer and a flow for oxygen to control the oxygen flow. It has a humidifier, and this is how it looks when the patient is wearing it. This is a different one called Vabotherm, and this is a unit. And actually, these two devices, especially the OptiFlow, has been tremendous addition to our tools to help patients. It has decreased the need for BiPAP, it has decreased the need for intubation, as well as allowed us to extubate patients early from the ventilators when they have severe diseases. And I'm not talking about COVID-19 patients in general, but in other patients before we struck with the COVID-19. This is how the Vabotherm cannula is smaller, it's more comfortable. The unit is having more precise digital numbers than the OptiFlow, and this is the mask for the BiPAP. And if you have dealt with BiPAP patients, the majority of the patients, they will have a leak from the mask, which will increase the risk of aerosolization. This is my last slide. The patients, when they need intubation, what we recommended is the most experienced patient, like Dr. Yusuf Al-Haji, to be the one to intubate, use rapid sequence intubation to paralyze the patient so the patient would not cough, use video laryngoscopy rather than direct laryngoscopy for such patients. And you minimize the presence of people in the room, except for those who are really needed to be there. The ventilator goals is to have a goal of venting the patients with a tidal volume 4 to 6 cc per kg of ideal body weight, with a goal of plateau pressure less than 30, following the ARDS network strategy, and having inline suctioning for adequate pulmonary toileting, and then maybe consider APRV and bilevel vent modes. However, I personally don't like these modes and highly discourage them. In the advanced management, if moderate severe, consider proning, contact the critical care or the consultant for ECMO. ECMO it has to be done in collaboration with cardiac surgery in our institution, and we have the perfusionists who are usually supervising the machines and taking care of it. We also use intermittent paralytics in these patients. We prefer that over continuous paralytics because of the potential complications later after the patient recovers. The majority of these patients, they don't get better quick. They will be sick and they remain sick, vent dependent on for at least 2 weeks, the majority of them. And the use of vasodilators like ibuprostanol, as we talked about earlier, for patients with hypoxemia. If you have any further questions in the future, please feel free to contact me through my email. I thank you for your attention.
شكرا لك دكتور محمد على المعلومات القيمة، بارك الله فيك، إن شاء الله في ميزان حسناتك. جزيل الشكر جزيل الشكر. الآن احنا حنخلوا الأسئلة في آخر الحوار لو سمحتوا. حننطلقوا الآن للدكتور يوسف الحاجي. تفضل دكتور يوسف، عرف بنفسك وتفضل.
السلام عليكم، كل سنة وانتم طيبين بمناسبة شهر رمضان المبارك. يوسف الحاجي، consultant anesthesiologist at Miami Valley Hospital. It's very good to have me with you guys. فالدكتور محمد التركي يتكلم على بعض الأشياء اللي هي بالنسبة ل intubation، فأنا نبي نعرج على الأشياء الباقية. يعني احنا what we use زي ما قال الدكتور محمد تركي، the most expert person for the COVID is 4 months old. فكل مستشفى نعم
share your slide دكتور احمد يوسفي من طرابلس.
I don't have slides. I don't have slides.
Okay, great. Go ahead.
دكتور احمد اهلا وسهلا.
فكل
هذا المخصص، جزء مخصص لجماعه الانستيزيا، جزاك الله خيرا.
Do I keep going? فيعني كل نتورك مع مستشفيات they come up with an idea or plan how to deal with these things. وزي ما قال الدكتور محمد, we try to learn from the Chinese experience and the European experience, mainly the Italian and Spain. In my network, we divide the patient two groups. يعني the people who actually supposedly to be healthy, and the way you know that when they call them with the pre-op screening, you know, they ask them about the fever, the cough, all these classic questions, and if they were in contact with somebody with the COVID. If they are not, they consider it not COVID. But again, although they are considered not COVID, but we don't deal with them with the old way. We still take an extra precautions. فالناس هادو عادة يجوا from the outpatient, and they come to our pre-op. We see them, they wear mask, we wear mask too. We don't wear the N95 except in the operating room when we do the intubation. So we interview them, nurses interview them, then we take them to the operating room. In the room, the anesthesia personnel, either the nurse or the doc, we wear the N95 mask from the time we take them to the OR. And if we go a month ago or 1.5 months ago, you know, the American Society of Anesthesiologists came out and says everybody get intubated. There is no MAC, there is no blocks, there is no actually LMA. But now recently, in the last 2 weeks, things start to change. Actually, you can do MAC, you can do LMA, or blocks, or intubate them. So the mode or the type of anesthesia, it's like before. We don't just intubate everybody. But unfortunately, sometimes we have this in my hospital, where nurse doesn't have an N95 mask. Sometimes even for simple procedure like transesophageal echo, we end up doing general anesthesia with intubation to protect our nurses. I don't know, I know it doesn't make sense, but unfortunately they don't have enough N95 mask to give it to all the nurses. So as I said, we wear the N95 mask. and then we pursue do the regular things. You have to pre-oxygenate the patient. We have to pre-oxygenate the patient for 4 to 5 minutes. And then we do rapid sequence, as Dr. Mohammed says, usually propofol and succinylcholine. And we use most of the time actually video laryngoscopy. You can use CMAC, Lightscope, RAF, whatever you have in your institution. And the reason to do that, so you don't get close to the patient mouth when you do direct laryngoscopy. With the video laryngoscopy, you still have enough distance. This is what we do for intubation. And then we keep the mask, 95 mask, for 20 minutes. And again, one point I forgot to say is we usually ask everybody in the room to move back or leave the room until we, sorry, guys, my phone dropped. To the anesthesia machine, then they can come back. And you know, our hospital recommendation came with an idea to keep your N95 mask for 20 minutes until the aerosolized particles, if it happens, settle down. And sometimes actually we put a blue towel on the patient face to help control it if they cough or something like that. But if you do rapid sequence, most of the time patient would not cough. And then the extubation. These are the most two critical times, the intubation and the extubation. That's when the risk of actually exposure to aerosolized particles from the patient. For the extubation, most of the people do extubation. If you have an LMA, keep them deep and they are breathing on their own, pull the LMA out, throw it in the garbage, put an oral airway and put a face mask on them and let them actually exhale the gas until they are awake. And some people actually, we still put another blue towel just to contain any aerosolization. And you can do exactly the same thing with the tube. You do deep extubation and then put an oral airway and face mask. I understand sometimes you cannot do deep extubation if you have people with a very high risk of aspiration, then you don't. You have to keep them awake. And unfortunately, there is a risk of exposure at that time because most of these people will cough, you know, when you extubate them. So you ask everybody to move back and you are wearing your N95 when you do extubation, live intubation. There are certain cases actually, which is, although they are supposedly they are with the category of normal patient, but just in case they are asymptomatic, you know, you wear actually the whole 9 yards gear of, you know, the double gloves, the N95, the and the gown. These are the specifically NT patient. But the whole procedure is in the mouth and the risk of aerosolization is high. So everybody in the room wear the whole full protection. And by the way, I want to mention something, you know, for people who have beard, you know, for the N95, you are not protected. So myself, actually, I had a beard since 2001. My wife and my kids never seen me without beards. I have to shave it actually. I don't know if that's a good or bad, but I had to shave it just to wear life. And every N95 person should be test fitted for that. Otherwise, I don't think you are protected. If the size is big or the size is small, you are not protected. I think you are fooling yourself by wearing the N95, but unfortunately you expose yourself to risk. And the easiest example is if you are wearing the N95 and you're wearing your glasses and the glasses get fogged, that means there is a leak and the N95 is not good. And actually the test is literally 15, 20 minutes. They spray certain actually material and if you taste that or not. So again, I don't know how they do it in Libya, but guys, just take extra precaution when you wear N95 if you are not fit tested for those. Then we go to the actually other group, which is the group of people who are high risk, which have respiratory symptoms, but they are not actually diagnosed by the test. And the other group is the confirmed COVID. We have 3 floors in the hospital actually, specifically for these patients, the COVID patients. And if we have COVID patient who's gonna have a surgery for whatever the reason, emergency surgery, I don't know, that could be anything, you know, and need to have a surgery, so we treat them completely different. Intubate them in their ICU. We intubate them in negative pressure room. And one thing for these patients, you know, you have to be very careful. As Dr. Muhammad said before, you have to actually wear all the protective equipment, the N95, the eye shield, you have to double gloves, you have to have the gown, and you have to have actually the shoe covers. You have to protect yourself first. Yes, you are there, you are to serve the patient, but again, you have to protect yourself first. And we do the same thing. We minimize the number of people needed in the ICU where we intubate them to decrease the risk of the exposure. You have only the essential people with you. And usually for us, physiologist and the nurse anesthetist, they will be wearing the whole 9 gears. And you're gonna actually intubate them like any other intubated patient. You're gonna do pre-oxygenation, especially for these patients. They are very sick. You have to pre-oxygenate them to increase the time, to give you time to intubate them during apnea. Number 2, you have to do rapid sequence intubation. Most of the time will be propofol and succinylcholine, unless it's contraindicated, the sucks, if they have renal failure, then you have to use the intubating dose of rocuronium. And then you must use video laryngoscopy in these patients. If you notice the first group, yeah, you prefer to use video laryngoscopy. You could do direct laryngoscopy, much preference for video laryngoscopy. But with this group, the confirmed COVID and suspicious COVID, you must use video laryngoscopy to decrease actually the distance between you and the patient. You don't need to come close to the patient's mouth to do the intubation. And then you're gonna hook them up to the, to the ventilator. What we intubate these patients actually, as I said, in the negative pressure room, and then we take them intubated to the OR to procedure there, because we don't want to contaminate the OR. Once you have a closed circuit, so theoretically the contamination is very low. And we transfer them with the ambu bag, and we transfer them with the actually filter on the ambu bag to filter any virus coming out. And there's one point I mentioned to say is operating room, we use actually an extra filter on the expiratory limb. All circuits have a filter at the elbow, but we use an extra filter at the expiratory limb. Again, there is no proof, it's not scientifically proved that actually will help you, but that's just an extra measure we do. And we keep that filter. We change the whole circuit, but we keep that filter in the machine. Again, because if we're gonna change that, we're gonna run out of supplies actually. So as I said, so if this patient gonna go to the room, you transport them, we're ventilating them on ambu bag, and you have a filter on the ambu bag to prevent, aerosolization. And one point here is when with the PPE, the sequence of putting it on, it's not important, because it's not, you're not going to be sterile, you're not going to break sterility. So you can put the gloves first, this first, but you have to put everything on. But taking it off, that's the trick, because if you make any mistakes, you contaminate yourself, and it's really, that defeat the purpose of wearing all that stuff. You wear that stuff to protect you. And we have actually a checklist where actually a nurse have that checklist, and you're still inside the contaminated room. And the nurse actually tell you, every time you take something off, either you wash your hands or you use alcohol to decontaminate your hands. What else? You know, before this section, actually, Dr. Lahdeli told me to do something about CPR. Actually, I wasn't ready for that. But there is one very important point here, which is you protect yourself. Before, you know, you're outside, the monitor starts alarming, you see the monitor flash, open the door, you rush and you start doing chest compression. Now it's completely different game. Now you have to protect yourself before you do any of that. So alarm goes off, monitor, you have to actually gear up. You have to wear all these things before you walk into the room to do the CPR, because protection is most important. Yes, you want to help the patient, but again, you have to protect yourself. And again, the CPR is the same CPR you do before. The only difference is wearing your protective equipment before you walk in and do the CPR. And I think I'm done through everything I have. Khalid, I think you can take over if there's questions, or we wait the questions until Dr. معتيق done.
شكرا يوسف، بارك الله فيك على المعلومات القيمة. ننتقل للدكتور محي الدين معتيق. زي ما قلنا الأسئلة حتكون في النهاية بإذن الله تعالى. حنفتح المجال للجماعة، كل واحد في علامة يد في الجنب يقدر يرفع يده وناخذ بالدور الأسئلة اللي بيتقدموا بها الإخوة. تفضل دكتور محي الدين. دكتور محي الدين.
لو سمحت تقدر تحط السلايد. تسمع فيها؟
نسمع فيك كويس.
تقدر تحط السلايد لو سمحت. أنوار. السلام عليكم، محي الدين معتيق معكم، cardiothoracic surgery. I'm the director of Ecmo in Mercy, Cincinnati. فاليوم نتكلم على use of Ecmo. I'm going to try to make it as broad as possible. This is a very complex and difficult topic to go through in 15 minutes. Like, and I try to simplify it as much as I could. Ecmo, so we're going to go through, next slide, please. We're going through, I call them the logarithm for my lectures. What's ECMO, indication conditions, cannulation site for ECMO, how to initiate ECMO, what you need to maintain ECMO, troubleshoot complications, and the machine itself called CardioHealth. There's a bunch of machines. This is what I mostly use. And I don't want to confuse everybody. There's 4 or 5 companies producing ECMO machines. What's ECMO? Basically, you have a pump. Next slide, please. You have a pump, and you have oxygenating membrane that will do the gas exchange for you. And you replace the heart and the lungs, or the lung only if you wish. So if you do veno-arterial ECMO, you are replacing the heart and the lung, meaning you're taking the blood from the venous and you're pushing it back to the arterial. That's where veno-arterial come from. So you go from the left side, from the right side of the body, which is the blue side, and you push it to the red side, which is the arterial side. And that replace the cardiac and the pulmonary, and we use it for people who have sick heart and diseased lung, or sick heart which lead to diseased lung. The other one is veno-venous ECMO, which is you take the blood from the venous side and you return it back to the venous side, and you use the heart to push that oxygenated blood through the sick lung. And usually what we do is we take the blood from the inferior vena cava and we push it back to the superior vena cava or to the right atrium. And the right atrium will contract, push it to the right ventricle, and to the pulmonary artery, and to circulate to the rest of the system. And for the purpose of this lecture, we're talking about COVID patients. There is utilization for both, depending on what's the patient presentation. And as you see, this is basically a mechanical device to replace the heart and the lung. That's the definition of ECMO, basically. Next slide. This is going through the arteriovenous, and what is the mean of the veno-arterial? You're taking the blood, as I said, and you perfuse it through the respiratory gas exchange. And once you produce oxygenated blood, you need a pump to push it back. If you are using it to the venous side, the pump will have lesser pressure. If you use it to the arterial side, you have to match the arterial system. And either you bypassing the heart or you bypassing the lung. And once you put the patient on a bypass, or you put the patient on the ECMO machine, you do not need most of those, which is vasopressor and inotropes. If you flow through the machine of 5 liters, that's basically the total cardiac output. And you could take basically the patient. Definitely, I stop all the inotropes. I pretty much leave them in a little bit of Miranon if needed to help vasodilations. And if the patient is completely vasodilated and needs some pressor, I use my target, usually vasopressin first. And if it's not available, I will use Levophed. And I do not use large amount of it, because remember, if you increase the total systemic vascular resistance, you will have issue with perfusing the patients. And if your total vascular resistance, the machine will alarm because you have a high pressure against the machine. Next slide. I will go through the indication. Those general indication that it's not related to our lecture only, but we could use it for cardiogenic shock, post-MI, pulmonary hypertension and right side heart failure, pulmonary embolism with hemodynamic compromisation, especially after the surgery, cardiac arrest. What's relative to our lecture is myocarditis. We learned from COVID patients, we have, unfortunately, we have 2 of them on ECMO last week not for the pulmonary issue, from the viral myocarditis. When those patients usually spiral down quickly, faster than the normal coming to the hospital, require a little bit of oxygen, increase oxygen demand, get intubated, and after that need PEEP and proning and all of that. They actually have cardiac failure or heart failure. This is why part of Dr. Turki lecture is saying that he needs cardiac enzyme. If your cardiac enzyme increase, that's a trigger to do an echo. If you have heart failure or what we describe as viral myocarditis, those patients usually end up on an echo. Next is, of course, for the veno-venous ECMO, is the end of the line for pulmonary critical care service. If they try proning, if they try ARDS strategy, regardless of what you believe, ABRV or bi-level ventilations, proning, high beep, whatever you believe in. Once we get the call for, we exhausted all the possible maneuvering we could do. That's the patient where I required an echo to prove that the pump is working. And after that, we will place them on veno-venous ECMO. And our strategy for those patients, usually because they require about 10 to 15 days on ECMO, is peripheral right groin for superior vena cava, for inferior vena cava. And we use 18 gauge arterial cannula for the superior vena cava. That's the inflow cannula. I call them outflow, which is the venous, and the inflow, which is the cannula that's going through to the patients. Next slide. Sorry.
I got lost a little bit. Which slide do you want?
The one after this one, please.
Contraindications?
Correct. Contraindication for ECMO in general, those when you reach an irreversible damage, you still have to go and check those patients. If they have multi-organ failure, if you think for some reason this patient have a CBR and it's CBR more than 30 minutes and there is no sign of spontaneous rhythm, if you did a CBR and the patient regain rhythm on and off, that doesn't mean it's a continuous or a continuous 30 minutes. If patients have some sort of malignancy, if the patient's native, or we don't think he is going to be a VAD candidate. For example, if you call me for a patient who's 80 years old, he have a viral myocarditis, and we're going to put him in ECMO. Usually we turn him down, and we have a conversation with the family. We set the limit for that around 75 years old, because the patient is not going to qualify for anything else if he's stuck on the ventilator, on the ECMO machine. Cannulation strategy, which is the most important part of my deal. I look at the patient in general to see the big picture. You have two groins and two necks for veno-venous. For veno-arterial, you have femoral artery, femoral vein, femoral artery, and femoral vein, right side and left side. So you have two sides. I usually try to separate the arterial cannula from the venous cannula. So I alternate. If I use the right side for venous, which my preference, the cannula is 25 French, basically the size of your thumb. And the arterial cannula is the size of your pinky, the small finger. The artery, I go to the left side because regardless, we have to set the cannula almost into the distal aorta. And for the venous, it will cross from the groin all the way up to the right atrium. So you have to cross the whole inferior vena cava to the mouth of through the right atrium on the mouth of the superior vena cava. That's for veno-arterial. For veno-venous, I use the right femoral vein, sorry. That's for outflow. And I use the right internal jugular for inflow. And I use size 21 arterial cannula there because it could bend easier. So the patient can move his neck right and left without compromising your flow. That's the paragraph. So next slide. Sorry, next slide, please. This will show you pretty much how we think about the ECMO machine. That's peripheral cannulations, and to the right, we use the femoral artery and the femoral vein. If you are doing a heart surgery, you usually use the central cannulation, which is through the aorta and the right atrium. For the purpose of this lecture, this is a central cannulation. Usually we are not using it. for purpose of this lecture, either we use the right groin or the left groin. If you are, again, if you are using the inferior vena cava, if you're doing a venovenous ECMO, you should go through the inferior vena cava for outflow, the blood going to the machine, and the superior vena cava for the inflow and using the heart as the pump. If you're using arteriovenous, you take the cannula and you put it in the femoral artery and you extend the cannula all the way to aorta. And this is how you generate the pressure. Next slide. This is how it's shown in the patients. Just a simple, I want to warn everybody, if you use the femoral artery, you have to use antegrade small cannula, because when you have a cannula in the leg for this long period of time, you could clot the distal femoral artery and you're going to lose the leg. And that's a death sentences, because basically the patients have necrosed muscle and it will release all those dead tissue and acidosis and lactic acid. One of the things we have to do, if the patient on ECMO, we check ABG and lactic acid at least once every hour for the first 6 hours. And after that, we go every 2 hours and we extend it after that every 6 hours. I almost exclusively place an antegrade cannula, 6 French, going downstream and hook it up to the inflow from the femoral cannula, femoral arterial cannula. Those the 2 links for if you, it's a YouTube, if you would like to see how the cannulation is performed. I don't do cut down anymore. Everything is percutaneous, and I use some what we call per-close device to close the artery and the vein if needed. I'm going to go through the machine itself. That's basically the Ecmo machine. That's the pump. The pump gives you some reading. The reading is, that's the SVO2 sat. This is the pressure in the artery. This is how many rap. Think about it as a motor, and the motor have to have a spin, and that's how many spin to generate this much flow, and this is how much sucking. So we usually limit the sucking to 100, meaning how much you're sucking in the venous side. We usually limit it to 100. We usually limit it to 200. And if the pressure above 200, remember what I said about the levofat, that could be the reason. If you are leaving too much volume in the patient and the patient pumping against the machine, you could have a higher pressure. And that's what's the pressure inside the line of the venous line. Of course, if you put somebody on ECMO, you have to anticoagulate them. For all purposes, I anticoagulate if the patient, we are coming out of surgery, of heart surgery, I wait for 12 hours, I actually reverse them completely. But for the purpose of COVID-19, we target, sorry, go to next slide, please. Those the website, I'm sorry, I have a slide here, so I'm kind of ahead of you. Those the website to see if you would like to watch how they do cannulation. Next slide. This is the machine. It's light machine. You can move it. It's a hand left. That's the Ecmo machine. That's the cardio-health. Next slide. This is the reading of as I said, this is that's 4.87 is how much cardiac output we are generating. Minus 61 is the amount of negative pressure we're applying to the venous. The 23 is the pressure in the venous line. 161 is the pressure inside the arterial line. 3035 is how many ram or run the motor is producing to generate this much cardiac output. And SVO2 is continuous measurement of the oxygen sat in the venous side. Next slide. Anticoagulation strategy. If you're doing heart surgery and you're coming with the ECMO, I usually reverse them completely and just restart heparin in 12 hours. And my goal is usually 50 to 60. If the patient is not yes, the same, my target is either heparin or Angiomax, depending on the patient exposure prior to heparin. If you have any exposure to heparin before the
محي صوتك يقطع.
heparin-induced thrombocytopenia out of the picture. Sorry. Is it?
No, it's okay. No, it's okay. السطر الأخير ممكن تعاوده لو سمحت.
So, as I said, the anticoagulation strategy, usually it's for after heart surgery, we don't do for 12 hours. If we start with Angiomax or heparin, depending on the patient exposure to heparin before, to avoid heparin-induced thrombocytopenia. If for the purpose of this lecture, if the patients have viral myocarditis, I usually, with COVID-19, I usually run the same parameters, which is about 50 to 70. The patients have ARDS and we're doing veno-venous for COVID, I usually run the anticoagulation 70 to 80. And we learned from multiple pathology slides, multiple data about thromboembolic phenomena on the COVID patients. So we try to run them a little bit higher than our standard. Complications with the Ecmo machine, infection, bleeding. Bleeding could be from the side, from the GI, and thrombosis lower extremities. Those the data and numbers. Weaning of ECMO, basically you let more volume go to the patients, slowly until the patient take over. So you go from 4 liter to 3 liter to 2. You basically have to make a decision there. I usually look at all the number. I run them for 2 liter for 2 hours. Once they are stabilized and I know their ABG, lactic acids, and urine output is adequate, I disconnect them. For oxygenation, I usually wean the ECMO as a vent. So I take the sweep. The sweep is the ventilation minute of the machine, which is basically measured by CO2. And I wean the O2 as we wean the O2 in the vent. So I go from 100% to 90% to 60%. And this way, if I'm doing it for veno-venous ECMO, I know their lung, because we are pushing the blood through the lung, I know the lung is doing the oxygenation. And once we reach to 40% of the oxygen and sweep to 0, and they are ventilated through their lung, I disconnect from the veno-venous ECMO. For the veno-arterial ECMO, I go down in the cardiac output. I don't touch the oxygenation. I go down to the cardiac output of 2 liter. And once they reach the 2 liter, I disconnect. Next slide. Hello. Next slide, please. As I said, you have to make a decision at some point what you're going to do with these patients. If you have ability to take care of them after placing them on ECMO, you should keep them. If you don't, you should transfer them to a bigger place. As I understand it, in Libya, we do not have ECMO, but if we do, most of the cardiac surgeons over there, they could place it easily. I think the problem with ECMO more of a maintenance because you need a experienced perfusionist to run the ECMO 24/7. You need multiple check on anticoagulation. You need multiple check on the rest of the lab, which will be the hemoglobin and lactic acid, base deficit, experienced nurses to look at extremities for ischemia. If you could do all of that, would be a good tool to add to the critical care team scope of support. For COVID-19, the two places I could see ECMO use, which we use it, we have two patients went into venous ECMO and came out. One of them have an interview in one of the TV. And right currently, I have one patient on with viral myocarditis on ECMO from COVID-19. As I said, those the two line you could see use ECMO for COVID-19. Thank you. Let me know if you have any questions.
شكرا دكتور محي الدين، بارك الله فيك على المعلومات القيمة. نبدأ بالأسئلة. دكتور هشام القبلاوي رفع يده، يتفضل دكتور هشام. في سؤال كذلك من دكتور رضا مزيقري، ممكن دكتور هشام كذلك يقدر يقول لنا عليه. تفضل دكتور هشام.
خالد، كان نقدر أنا عندي تعقيب بسيط على محاضرة دكتور محي الدين بالنسبة للإكمو. That's one part that the machine cannulation and how to operate the machine, oxygenate the patient. But there is the patient that still needs a lot of care while they are on the ECMO machine. One of the strategies how to ventilate these patients, because you cannot keep them on the ventilator with the traditional or even low total volume strategy while they are on the ECMO. The whole idea about putting patients on the ECMO is to rest their lungs if it's done for ARDS. So there is different studies. There is no consensus on what is the ideal total volume, but probably we use between 150 to 200 cc total volume for those patients, which is barely ventilating these patients. What that leads to is a lot of secretions get accumulated and then become dried up and cause mucus plugs. And these patients will require bronchoscopy and cleaning of their airways, if not every day, every other day. If you go several days without bronching these patients, then you will end up doing a procedure for a long time. I had a patient I bronch for 4 hours just to clean up all his airways from the mucus plugs that became like cast. جزاكم الله خير.
بعد اذنك يا محمد، غير بنعقب تقريبا طبعا درت شويه transplant heart and lung transplant, and we did significant amount of try to put them in a traditional. Don't take the tidal volume down to 150. Try to do 4 to 500. I mean 4 to 5 cc per kilogram, and see if that make a difference. So I don't bring their tidal volume down. I don't take their PEEPs down. I actually encourage more aggressive maneuvering to the lung.
شكرا دكتور أحمد، شكرا دكتور محمد. دكتور هشام قبلاوي تفضل، وبعد الدكتور أحمد البوسيفي.
السلام عليكم، مشكورين جدا محمد ويوسف ومحي على البرزنتيشن هذه. سؤالي مانيش عارف محمد إذا كان عندكم experience with any COVID with pregnancy. If we extrapolate things, to influenza or the seasonal flu, pregnant women, especially in the 3rd trimester, they get worse. If they compare themselves to counterparts, they're not pregnant at the same age. And I know that there isn't enough data in there, but I'm just looking into if you have any personal experience with any pregnant woman who had a COVID since you have a significant number of patients at your institution. So I appreciate your answer. By the way, Rida Mzagri is using my account, so you may see Hisham Kiblawi twice, so he will ask his question by himself. Thank you.
I was wondering about that, Hisham. So regarding the question, every time I have a pregnant patient in the ICU, I'm very anxious about it because it's like trial lawyers all over their head, very high risk patients. And just to be specific about answering your question, in COVID-19, for very unclear reasons, we have not had a single pregnant woman that ended up in the intensive care unit. I'm not aware of patients who are pregnant that were admitted with COVID-19. The majority of the patients we have in our hospitals are really probably about more than 70% are Hispanics, and probably another 15% are African Americans, and the rest are Caucasians. So, but I don't have much experience in such patients.
I interfere about that. We have experienced about 3 pregnant women, and none of them went to the ICU. And we did test the baby after they're born twice, and they were negative. But we had those experience in the DC area.
شكرا لكم. الدكتور احمد البوسيفي تفضل، عندك سؤال، وحنرجع للدكتور رضا مزاقري بعد دكتور احمد البوسيفي. دكتور احمد البوسيفي.
السلام عليكم ورحمة الله.
عليكم السلام.
أولا كل عام وأنتم بخير بمناسبة رمضان طبعا لكل الزملاء. وإذا كان سألت الدكتور محي الدين على موضوع if we think in near future about ECMO, is it easy to be our experience here? As you know, there is no ECMO, and if we build up the ECMO lab, is it easy to using the phenylvenous or phenyl arterial? And for training, it's a very important for our colleagues here. It's a very important rather than COVID module, because we can use ECMO for many indications, as you mentioned, Muhyiddin. This is the first question. And second, if we're coming back, and now there's a debate about even the diagnosis about and screening about rapid test and qualitative, quantitative, and even about PCR and using of high resolution CT. And there's many discussions, of course, regarding the issue, because nowadays, thanks for God, of course, we have no many cases. We thinking about to starting a mass screening here in Libya about about even to bending the curve and to be know exactly if there's any new cases, of course. If you have any experience about the rapid test qualitative, to be screened and even to touch, giving a clue for any flow of patient, it's a very important, as you know, as a 10 to 15 minutes to be using that, beside, of course, other criteria, and to be after the rapid test, if we can also, if there's facility to using the ELISA for qualitative IgM and IgG, and of course, we know about real-time PCR and PCR and high resolution. As we know, the high resolution, we can't using as screening and even to be for every patient, as you know, about the harmful of radiology. Thank you. I have this 2 comments or 2 questions for ECMO and for diagnosis and screening.
تفضل دكتور محي الدين ودكتور محمد.
قولي محمد يمشي. محمد تفضل.
بالنسبة للسؤال يعني كان طويل جدا وفي شوية ما عرفتش يعني بالضبط، بس على ما فهمت إن هل بالاستطاعة إحضار جهاز الأكمو ويكون في يوتيليتي في ليبيا طبعا يعني لو تلاحظ حتى في المستشفيات في العالم مش كل مستشفى عندها الإكمو ماشينز، وعادة يكون في certain centers اللي هم فيهم الإكمو، ويكون في highly trained يعني متدربين على الجهاز هذا، لأن لو الإكمو يشتغل بناس ما يكونش عندهم خبرة كفاية فبالتالي حيكون في complications كثيرة. يعني هو مش مجرد تركيب جهاز بس، يعني العناية بالمريض ككل مهم جدا. ف والله أعلم، أنا ما ليس لي دراية بالأشياء كلها الموجودة والمتاحة، بس على ما أظن في أشياء ذات أولوية قبل ما يكون الجهاز الأكمو موجود، على أساس يتم تحسينها حتى يتحسن بالنسبة لل يعني علاج المرضى في العناية المركزة والعناية الفائقة. أما بالنسبة للتاس ففي شركات كثيرة جدا يعني بتتنافس على ما هو التست بتاعهم يكون الأفضل. فزي ما يقولوا the jury is still out، يعني ما زال ما فيش حد يقدر يفصل في هذا الموضوع بالنسبة للبي سي ار. أما بالنسبة للأنتي بوديز هذا يعني موضوع ربما الدكتور يحيى تجوري يقدر يتكلم عليه.
دكتور يحيى.
Okay. شكرا. بالنسبة okay, the best diagnostic methodology is the PCR, no doubt about this. Okay. There is several companies out there. There is the mass testing equipment, and there is a single testing machine also, like a QI-STAT. We use the QI-STAT because it gives us the ability also to do the upper respiratory viral panel testing, as well as the COVID-19. And some of the old COVID also is available in this machine. The Gene Expert is about 45-minute testing, and it's available. And we have up to 16 every 45 minutes. We can turn around this type of things. Roche have also a mass testing ability with a PCR with BDX Max. Also that. Now, said that in the state there is a limiting amount of reagents as well as collecting samples. Therefore, we choose not to test except the symptomatic patients, and we recommend that. And I believe there's also most of the European countries were in the same category where they test only the symptomatic patients. Now, the second part of the questions, the immunoglobulins, IgG and IgM. Okay, the problem with this, when we investigated that, the sensitivity and specificity for this for COVID-19 is not really a good high sensitivity and specificity, and therefore we chose not to do them. That's one thing. The other thing is we did not know what to do with the result, whether if it's positive, because as you know, IgG that's been exposed, is he in a state of infectious process or not? So if you want to quarantine these patients, then it's better to do with a PCR testing for an accurate testing accurate results, as well as a good indicator that this patient is still actively sick and his potential can infect other people. Did this explain the questions? And I know, but I would like to add also, because I involved in a lot of Middle Eastern hospitals inspections, I do believe that in the Gulf, Saudi Arabia and Gulf, they are trying to do the IgG, IgM as a mass productions testing, but I don't know if they are actually did it or not. It's available there, but if they went into as active testing or not, I cannot answer these questions.
شكرا دكتور يحيى. دكتور
السلام عليكم.
محي تفضل.
خلينا نكمل بس على موضوع الأكمو، لأن there's two basic questions for ECMO في ليبيا. الquestion الأول, do we need ECMO facility? The short answer is yes. The long answer, how to get there. لأن احنا في multiple places يديروا في cardiac surgery. So in this time or era, you cannot provide cardiac surgery without ECMO support. That's the short answer. The long answer, أنا جيت لي Mercy 4.5 years ago. When I came, we did not have ECMO. So we started by building the block. Nursing training first, it took about 6 months. But then we opened ECMO only for post-heart surgery. يعني لما تحاول تكمل from off bypass and تحط المريض على الإكمو. وبعدين بعتنا الممرضات بتاعنا to different institutions to be trained and certified and brought them back. With all of this said, وبعدين we opened for the cath lab, crash on ECMO. Or after that, we opened the last part, which is the veno-venous ECMO. So, and you cannot do it for COVID only. There is no way to distribute yourself this far. Plus, the patients will cost you, the cost بتاع الECMO. The machine itself is easy. The circuit, the nursing staff, the supporting staff, cost and training is tremendous. So I would not, hello?
نسمع فيك.
What I will, for the short answer, yes, you need an ECMO center. واحد منهم مركز طرابلس الطبي. I don't know if still they do heart surgery. لما كنت غادي كانوا وإلا مستشفى تجورة. They should have an ECMO, at least to support post-cardiotomy, post-heart surgery. And it should start there, not anywhere else. لابد يكونوا يديروا في heart surgery. يا إما في مركز بنغازي، لأن مركز بنغازي يدير في heart surgery دكتور عمر. وهذا كلهم they are able. It's not very hard to implement the machine. The care of the patient is a bigger deal, and the maintaining of training is a bigger deal. We have issues to maintain training here either too. So that's where the step is. So yes, you could. The short answer. Do we have the capability? It's easy. You could do it. Can we do it? Yes, but it needs a lot of effort and work, and it should be limited to one place where their heart surgery is available.
شكرا محي. دكتور خالد هديري، عندك تعليق على إكمو؟ قلت لي تفضل.
أهلا، تسمعوا فيه تمام؟
تمام واضح.
Okay. No, just a small addition. I want to say that we added this lecture about ECMO for completeness, and it is a valuable tool to have in Libya indeed. However, pertaining to the COVID situation, even centers in the US that we used to use ECMO, for example, we use ECMO in different situations, and we have not used it at all. And I think I heard Mohammed saying they didn't have the patient on ECMO. So the role of ECMO in COVID is still very, very last resort, and that is because the group in China started with that in late February, and they came up with data showing that mortality after you put ECMO exceeds 50%, and the mortality of people, as we know now, who are in the very severe stage, as Dr. Mohammed alluded to, is not far from that. So at this point, there's no benefit from adding ECMO. However, centers that are set and ready for ECMO and have ECMO as a last resort for patients who are, in other words, should be saved because they're young and and we have better perspectives, they tend to use ECMO, but for the majority, it cannot be considered at this stage. This is just the point I wanted to make pertaining to the COVID pandemic.
شكرا. شكرا. دكتور إدام زيغري موجود؟
أهلا وسهلا بكم.
تفضل.
ثلاث أسئلة دكتور محمد بالنسبة للأنتيكواجوليشن based على ال different report in the pathophysiology coagulation the small vessels ولا just shooting in the air. That's one. Second question is I missed the procalcitonin, if you could clarify that. And the third one is if there is any average cost per patient who went to the ICU, what is the average cost by the time he leave the hospital? تعقيب آخر طبعا excuse my for some people if they think it's rude, but Libya does not need COVID. We need صابون في حمامات المستشفيات أول شيء قبل أي شيء آخر لغسل اليدين. تفضل محمد.
السؤال الأول بالنسبة للأنتيكواجوليشن, what we have noticed is that a lot of patients, they have elevated D-dimer. And what it means that there is a stimulation of the coagulation cascade. And later, for some of the patients did have thrombosis, either deep venous thrombosis in their lower extremities, or they have acute pulmonary embolism. The majority of the patients, the thrombosis was in the peripheral veins, which made us think probably this is more of thrombosis rather than embolization. So what we did, and from the beginning is that we base our anticoagulation on the D-dimer and the severity of the disease. Any patient with moderate severe disease and D-dimer more than 5, and I have to explain that there is more than one way to measure the D-dimer. What we do in the hospital is measure the quantitative D-dimer. Before it was, I think, the total D-dimer, and that was in hundreds. So if the D-dimer level is more than 2.5 or 5, we anticoagulate these patients unless there is absolute contraindication. Regarding the procalcitonin, the reason we do it in the beginning, just to make sure that there's no coexisting bacterial pneumonia, or the patient has bacterial pneumonia. A lot of them, they come in, they are sick, they have pneumonia on the chest x-ray. In the early days, the test took about 7 days to come back. So we needed to make sure that we treat these patients appropriately. And that's why we do procalcitonin when they come, put them on broad spectrum antibiotics, repeat the procalcitonin the second day, which is about 24 hours from the first time. And if it's negative or just a little bit elevated, then we discontinue the antibiotics, because we all know that procalcitonin is very high in bacterial pneumonia or sepsis in general. And I don't remember the third question.
The second part, is it commonly used in your institution, procalcitonin as a parameter for infection, like
yes.
ESR, C-reactive protein?
Yeah, we use it a lot actually in patients with sepsis in general, especially pneumonia, and that helps in directing the antibiotics. So sometimes you have a patient with clinical radiographic picture of pneumonia, but clinically it's equivocal. Like you cannot tell is it or not. And if it remains negative and the white count is not very high, it helps you to make that decision to discontinue the antibiotics or to continue. I have to say also that sometimes we neglect it and just treat the patient on the clinical basis. And the short answer, yes, we use it a lot.
But generally, is it more stronger than ESR C-reactive protein? Just for future reference.
Yes. C-reactive protein and ESR is non-specific for any inflammation. Procalcitonin is more for bacterial infections.
Okay, thank you. The last question is, maybe it's too early, but just average cost for a patient goes to the ICU with the COVID-19. By the time he leaves, what is the bill?
Well, it depends on the hospital and what they need. If they need mechanical ventilation or not, if they need those advanced therapies like tocilizumab or plasma, the doses are like those medications. Each dosage you're talking about several $1,000s. So the frustrating part about these patients, they get sick and they don't get better. So they will be intubated, chilling on a ventilator for 2 weeks before you can even start weaning them. So you're talking about several $100,000 cost for each patient when they leave the hospital.
Okay, thank you.
شكرا دكتور احمد.
Can I add something here? I believe
دكتور يحيى من بكري يستنى هو دكتور احمد. دكتور احمد خليفه شنو السؤال بتاعك بعدين نجوك دكتور يحيى. دكتور احمد خليفه مش موجود. تفضل دكتور يحيى تعلق.
الحكومة الفدرالية تكفلت بمصاريف الكوفي medication and handling, I believe.
شكرا. دكتور بلامين. دكتور بلامين.
تسمع فيها؟
ايوه اهلا وسهلا تفضل دكتور.
انا دكتور محمد غيث بلامين من عنايه الباطنه ميديكال اي سي يو في مركز الترابط الطبي.
اهلا وسهلا.
طبعا بس كان عندي سؤال لكن تقريبا جاوب عليه الدكتور محي الدين اللي هو كان موضوع الايكمو كيف نبدا في البرنامج. هو من اسابيع فاتوا تقريبا جونا جماعه شركه من الشركات وعرضت ان نبدا في برنامج الايكمو. طبعا طلبوا منا ان نكونوا تيم، تمام، فاحنا اخترنا اشخاص للموضوع هذا لكن قاعدين ما بدناش في الموضوع. فكان نبو من ضمن الحاجات اللي نبوها يعني نبو مساعده في كيف بدايه البرنامج الايكمو. طبعا برنامج الايكمو اكيد بيكون برنامج كبير، برنامج على مستوى الوزاره، برنامج على مستوى البلاد. فالسؤال كان للدكتور محي الدين كيف نقدروا نبدو في تكوين تيم زي توا، وشن هي الحاجات اللي نبوها في المستقبل، أو تقريبا قداش نبو باش نقدروا نبدو في توصيل البيشنت بالايكمو 6 شهور سنه من التدريب من الحالات هي. فكان هذا بس سؤالي. شكرا.
السلام عليكم. والله خالد نقول لك ممكن خالد
ايوه
ممكن نديروا يوم ثاني نحطوا just a lecture على الاكما و how to start a program. الحقيقة أن هي process وطويل الموضوع، وبعدين في set of complications you have to be careful with. ولكن you need very good qualified nurses trained. احنا نديروا في distribution 2-to-1 معناها 2 nurses per patient. You need at least 4 to 5 perfusionists to set up because you have to make a decision من اللي بيتحكم في الإكمو ومن اللي بيتعلم الماشين، perfusionist ولا النيرس. كان بتدير النيرس معناته ب 3-to-1 per patient. كان بتدير perfusionist you need 2 nurses and 1 perfusionist. وبعدين you have to set up the implanter and the explanter. شو معناها؟ معناها من اللي بيحط الماكينة ومن اللي بيحولها. بعدين who's gonna manage the machine through the week مثلا. Who's gonna adjust the machine up and down and do all of that. And how he's gonna interact with the other teams اللي هو البلمونري. انت من الباطنة. انت من الباطنة you can't implant. يعني تبي cardiac surgeon to implant for you.
في تفاهم بينه وبين الدكتور خالد بن طالب.
سويني خالد
بن طالب. هو تو الكارديو سيرجن في التي ام سي وهو موافق على الفكره. بس عندنا 5 بريفيجنست اوكي يخدموا مع الدكتور خالد وعلى الكارديو سيرجري، فهم كانوا ممانعين انه يخشوا في الموضوع هذا بحكم انه اكسترا جوب فور ذم.
فكانوا not only extra job they have to be 24/7 in the hospital. معناها بيديروا شفت كل 12 ساعه. فهمتني؟ وبعدين الامبلانتر والاكسبلانتر who's going to manage the ECMO machine؟
هذا كله قاعد
من اللي بيعدل الماكينه؟
المفروض الانتنسيفست يعني.
No, that's not true.
Okay, that's why we need.
So you need the cardiac surgeon. You need the cardiac surgeon to adjust the machine up and down. The intensivist adjust the ventilator. الدريبس اللي هم الفازوبريسنز والحاجات معهم هذوما they run by the cardiac surgeon and the machine is run by the cardiac surgeon for both for veno-venous and for veno-arterial. ولا أظن مع احترامي يعني لا أظن أخطأ من اللي نعرفهم أنا يعني ممكن حسن المقور وخالد سوينيا وممكن دكتور خالد وريد they could do this job.
يا دكتور بالأمين ممكن just ملاحظة بس يعني كنا نتمنى يكون فيه أفضل يعني الأجهزة والمعدات والأدوية لعلاج المرضى في ليبيا، لكن المنطق أن الإنسان يبدأ بما هو الأساس حتى يبني عليه. على سبيل المثال أنا يعني في الانتنسيف كير يونت ونشتغل لي يعني عدد سنوات كبيرة، فمن الخبرة متاعي مش كل مريض يحتاجه. بالنسبة للكوفيد هذا إن شاء الله مرحلة وتمر، لكن في المستقبل يعني حتى لما داروا الستاديز على ال ARDS patients what they found that if you prone patients and you use low tidal volume strategies for these patients, a lot of them they did as good as the ones who end up needing the ECMO. The ECMO patients, not everyone goes on it. There is a lot of restrictions. They cannot be in renal failure and requiring dialysis. They cannot have high BMI, meaning they cannot be morbidly obese. And at each institution, they have their cutoff on which BMI they will use. But what I'm saying is there is a lot of other things. Probably we should focus on getting, including like, I don't know, do we have inhaled epiprostinil in Libya?
فقبل الفلوفانت they don't have a proning beds, so proning beds is first. بعدين معلش let's do a different lecture on ECMO.
نتفق معك وحيد.
بالضبط. لينا بعدين نقول لك يا دكتور بالأمين الإكمو should start in the cardiac surgery unit, not in the intensive care unit. It's the other way around.
That's the plan دكتور. هذه الخطة أنا نبدأ في الأول مع الدكتور في التوراسيك سيرجري بعد الكاردياك سيرجري بعدين نوسع الموضوع.
لما توصلوا غالية I will be more than happy to come and help.
دكتور بالأمين الإيميل متاعك أبعته في الشات وتو احنا نحاول نتواصلوا معك مع الترتيب في يوم معين يكون فيه دكتور محي الدين ودكاترة متاعكم كلهم تاع الكارديو سيرجري اللي هم انترستد، الانفيوجنست، البرفيوجنست، الناس نتاع الميديكال اللي ممكن يتعاونوا نديروا محاضرة خاصة خلال الأيام الجاية. في دكتور محمود.
أوكي تمام.
نعم محي تفضل.
أنا عندي about 4 lectures, each one of them 2 hours for either the دكاترة ولا ممرضات حتى الممرضات. This is how we started the program here. Again أنا أيد كلام دكتور محمد تركي. You need proning beds, you need flow vent, you need this. The basic, ECMO is the last thing on the whole deal, kind of. فما تقدرش تمشي لللاست ديل قبل ما يكون عندك البيسكس.
شكرا جزيلا لك. دكتور محمود عندك سؤال؟
ايوه السلام عليكم.
وعليكم السلام.
وعليكم السلام.
دكتور محمود نسمع فيك تفضل.
timing of antiviral treatment اللي هو supposed antiviral treatment زي مثلا الهيدروكسيكلوروكوين والريمديزيفير وعلى حتى الفافيليفير timing exact timing زي ما احنا عارفين ان في 2 phases للكوفيد، في الفيريميا والفيرولوجي فيس وفي الابنورمال اميون ريسبونس. فامتى انا كانتنسيفست ولا في الانتنسيف كير يونت
لما يجي المريض الاكزاكت تايم اني ستارت الانتي فايرال تريتمنت السبوزد انتي فايرال تريتمنت هذه، هل نبداها يعني لما يخش في المالتي اورجان فيلير معناها هو او حتى الاي ار دي اس ممكن يكون هو خاش في الهايبر انفلاماتوري ريسبونس. سو اعتقد ان الاتجاه حيكون في السبريشن بتاع الانفلاماتوري والاميون ريسبونس اكثر من انه يكون في اتجاه ستارتنج الانتي فايرال تريتمنت. هذه نقطه. النقطه الثانيه الملاحظه على الاور بيشنت اللي في الاور كنتري هنايا ان هم سنجل اورجان فيلير ومايلد تو مودريت هايبوكسيميك ستيج، ولكن في بعض منهم يكونوا رينال فيلير. اوكي. وشاهدوا في حاجات في حالات ان السي تي سكان بوزيتيف والبي سي ار نيجاتيف. فهل احنا نغيروا من الواي اوف سامبلينج؟ وهذا السؤال الدكتور يحيى، يعني سامبلينج بيكون من other fluid specimen يعني او من السامبلينج نفسها ما تكونش من upper respiratory tract، او شنو هو القصه في الفيروس تايب اللي عندنا هنا. هذه نقطه. السؤال اللي بعده ان هل في سيفيريتي سكور اندكس لما نخصص المريض الاي سي يو باش نعرف انه هو هذا البروجنوزس بتاعه جود ولا نو، يعني سبيسيفيك سكور للكوفيد، ولا نعتمد على السكور اللي هو التراديشنال سكور في الاي سي يو زي الاباتشي وغيرها. بالاضافه الى ان في نقطه اللي هي البروكالسيتينين. البروكالسيتينين احنا نعرف انه هو يزيد حتى في السيتوكين ستول مع السي ار بي، فكيف نفرق بين ما بيناتهم زوز؟ يعني ما بين انه هو سوبر ادد انفكشن بكتيريال انفكشن ولا سيتو
صوتك انقطع.
مع البيبي متاعها سيفير ار دي اس وبعد البرونينج وكل شيء، للاسف شيء نيد ان هي يندر لها اكمو فاسيلتي. ومصر عندهم اكمو فاسيلتي، تونس عندهم اكمو فاسيلتي، واحنا ما عندناش. انا نعرف الاولويات وكاتب ضد سيرتيفيكيت المريضه في ديوتي ما فيش شيء ممرضه. الاولويات اكيده لها دور، لكن حتى الاداره الرشيده حتكون والمستقبل والاصرار حتى هو مهم. وشكرا لكم.
شكرا دكتور محمود. دكتور محمد تقريبا متفضل تعلق على السؤال.
والله هي الأسئلة كان الكومنتس طويلة، فعلى ما أظن ما اللي عرفته سؤال على
استعمال انتي فايرال رول اوف انتي فايرال وامتى يكون موجود؟
تايمينج.
بالنسبة للهيدروكسيكلوروكوين is not antiviral, it's antimalarial. And it is used in those patients, and we don't even know what is the true effect. When you use them as soon as the patient starts to have shortness of breath or hypoxemia. If the patient has positive test and they're asymptomatic, or they have just viral syndrome, meaning little fever and feeling a little congested, then you don't treat them with hydroxychloroquine. Regarding the remdesivir, it is not available, so we don't have to worry about that, even in the United States. When it's available, probably it should be used in moderate cases as soon as they're I'm sure that the algorithm will change. Probably they may be able to check the PCR for the virus in the blood, or there will be other techniques of figuring out the viremia. Regarding the procalcitonin, it is not elevated in COVID-19 patients, even though they have very high inflammatory markers. They usually it is either negative or mildly elevated, barely mildly elevated. In bacterial infections, becomes very high, and usually we see increase in the procalcitonin when they have secondary bacterial pneumonia. Regarding the negative test and the patient has the symptoms, I have at least 2 patients who presented with typical COVID syndrome in terms of high inflammatory markers, respiratory failure. They needed to be intubated, and one of them did not need to be intubated. But one of them was exposed to, both of them exposed to COVID-19 individuals, and one of them tested negative twice, the other one tested negative 3 times. But we treated them as COVID, and we kept them in isolation for the time being they were in the intensive care unit.
شكرا جزيلا لك. في الدكتور أحمد خليفة سأل سؤال مش واضح الحقيقة، لو كان يقدر من فضلك يخش يقوله لنا. دكتور أحمد خليفة يسأل في الدكتور التركي. دكتور أحمد خليفة. تفضل دكتور. ما نسمعوش فيك، تفضل. دكتور أحمد.
شكله مش موجود، نرجعوا له.
دكتور عبد الرؤوف الشاوش. رضا مزيقري.
السلام عليكم.
وعليكم السلام. تفضل.
شكرا بارك الله فيكم على sharing your information والمعلومات القيمة اللي تعطوها. لكن احنا لاحظنا ان توانين احد الطبيب نخدم في حالات العزل في المنطقة. نبي نسأل سؤال بس تو احنا واجهتنا مشكلة ان البيشنت دي دائما متاع البيشنت اللي نخدموا عليه تو حاليا دي دائما متاع بادي كان في الاول بادي ريزنج اب وحطيناه على الفول انتيكواجولانت هيبرين. تو عملنا له امس البي سي ار كان نيجاتيف ونبون والكلينيكال البيشنت ستيل تكبنك ودزنك باهي ستيل نيد اوكسجين. بس احنا نبون هل في رول للبرولونجد ثيرابي للانتي كواجوليشن حتى بعد الديسشارج؟ نبون نعرف امتى نديروا ديسشارج للبيشنت اذا كان كلينيكالي البيشنت هو استريح نوت كبنك نوت دزنك وتحسن كلينيكالي، لكن الدي دايمر ستيل ريز ونبقى قصه الانتي كواجوليشن فول انتي كواجوليشن. هل نستمر على فول انتي كواجوليشن ثيرابيوتيك دوز ولا نحطوه على بروفايلاكتيك بس؟ واللي امتى كم الزمن كم الوقت؟
دكتور محمد تفضل.
سؤال ممتاز جدا. بالنسبة للمريض حتى لو كان التست نيجاتيف وأنت يعني عندك أنت شك في أنه هو عنده الفيروس والمرض، فبالتالي لازم تعالجه كأنه عنده مرض، لأن نسبة الفولس نيجاتيف في التست هذه يعني يعتمد عليه وين تقرأ تكون توصل لحوالي 30%. فعندك يعني من كل 10 أشخاص 3 منهم عندهم الفيروس وعندهم والتست بتاعهم نيجاتيف، ف you treat them as COVID. بالنسبة للانتيكواجوليشن if they are moderate and their D-dimer is high, then you fully anticoagulate them. And if the D-dimer trends down quickly, probably you just switch them to prophylactic dose. And if the D-dimer remains high, then what do? You just fully anticoagulate them. No one knows what is the right answer regarding the duration. It could be 4 to 6 weeks. So you can pick a number and you're not wrong. 4 to 6 weeks of full anticoagulation. What we do in general to be certain about should I stop it in 4 weeks or 6 weeks, maybe it's a good idea to repeat the D-dimer at that time. If the D-dimer is normal, then probably you can feel more comfortable to discontinue the anticoagulation. But if it's elevated at 4 weeks, maybe you want to add 2 more weeks, check it again and see if it's normal, and then you can stop it. Regarding when you can discharge the patient, I think, you know, once their oxygen level is back to normal, or they can go home on oxygen supplement that is available to provide for them.
Even at home, full anticoagulant therapeutic dose.
Yes.
Okay.
Yes.
Okay. how frequent I can do D-dimer, every 3 days or 5 days or weekly?
If you decided to anticoagulate them, you can just maybe do it a week later to see, just before they get discharged. And initially you need to do it probably every 3 days. But later, if you commit them to anticoagulation, probably before discharge, you can check it again and see if it's back to normal, then probably you don't need to anticoagulate them fully. But if it remains high, then you just put them on full anticoagulation for 4 to 6 weeks.
Okay, thanks a lot. Thanks.
If you have any questions, I'll be happy to give you my email and phone number, and you can call me through WhatsApp, and I can help you, inshallah.
We hope that, Wallah. I hope that.
Inshallah.
Okay, thank you, دكتور.
دكتور محمد لو كان تحط الايميل بتاعك في الشات in general so they can get in contact with you. دكتور مش عارف هشام القبلاوي، لكن الباين هو دكتور رضا زيغري، ولا هو قديم رفع اليد هذا كذا. خلينا نمشي للدكتور.
لا والله هو رضا طلع من الكونفرنس، لكن عندي سؤال اذا كان الوقت يسمح وما فيش حتى يعني عارف خديت فرصتي يعني.
بعدين في محمود سالم هو بيسأل سؤال ثاني حتى هو. محمود.
ايوه
تفضل.
بالنسبه للدكتور التركي لقصه الدي دايمر، هل في بنفيت ان نديروا adjunctive with fibrinogen level معاه to decide ان هذه starting full anticoagulation او حتى stop anticoagulation اذا كان في evidence of hypercoagulated state؟ في الإلستوغراف ما نعرفش، احنا مش متوفر عندنا، لكن هل نديروا معاه الفايبرونيجين والدي دايمر جميع او لا؟
دكتور محمد. دكتور محمد تفضل جاوب على السؤال.
Can you hear me now?
Yes.
So regarding the D-dimer and fibrinogen is usually checked just to rule out the possibility of intravascular, disseminated intravascular coagulation, which is DIC. If it's elevated, and I have not seen patients with low fibrinogen except probably one. The majority of them, it's either normal or elevated. The short answer is no, you don't need to check fibrinogen all the time on these patients. You can just trend the D-dimer. And you don't have to do any other tests.
شكرا. دكتور هشام.
خالد can I add بالنسبة للدي اي سي we don't use fibrinogen anymore. Okay. If you want to follow with factor 10, active factor 10.
شكرا دكتور يحيى.
Let me make a comment about Dr. Yahya's. The reason why it is important to follow the fibrinogen in DIC is because if it drops below 150, then you have to replace it and give the patients cryoprecipitates. So they will not have worsening symptoms and disease.
شكرا لك دكتور هشام. تقريبا ما عادش فيه لدكتور هشام عشان we conclude.
This question really is for everybody. We know here in the United States that minorities, maybe African Americans, their prognosis are the worst, and the mortality rate is much higher than other ethnic groups and amongst the whites. My question is, in the United Kingdom, it appears that healthcare providers, minorities in the health system are affected the most. Doctors and nurses, not Caucasian, not white European, are affected the most. Is anybody aware or any thoughts of maybe there is some genetic predisposition, maybe people who had a vaccination? Any idea? You may not have an answer, but at least if we could have some discussions or any ideas, or at least maybe from your own institution, what did you see?
I guess إن الماينورتيز محررين أكثر من البيض يعني. They don't take care of themselves.
في حد معنا من بريطانيا يقدر يعطينا لو كان عنده أي
بالنسبة للتجربة متاعنا هنا في Pennsylvania, the majority are Hispanics and African Americans. And the reason for it, one, because unfortunately they don't follow the rules of social distancing and taking the rules seriously. They usually live, a lot of people live together and they can spread the disease to one another. A lot of cases have been spread from New York, so they have families in New York, they bring them over to our area and bring the virus, and then the entire family, they will get it. I have two examples of two Hispanic families. They had the virus, the mother died, the daughter made it. I have another example that the grandmother died of African-American family. The daughter almost died and she was trached and sent to a rehab, and the daughter did not get sick. So I think just the ignorance of these people just put them at higher risk of getting the disease. Regarding ethnicity, there is studies going on regarding the BCG, as Khaled alluded to, in Australia and I think somewhere else, and just to see if BCG has an effect in the immunity. The bigger question is why India did not have a lot of patients. We know they are not declaring the true numbers, but some people said maybe it's diet. Yesterday, Khaled قال الشلولة في مصر was like the treatment, but probably the diet in India might have some protection for them. Wallahu alam.
Yeah, my question is, if we look at the ratio of doctors in the United Kingdom, population, and how many Libyan doctors are practicing there. So far, I'm aware of 4. One is still in ICU, one got out, one sadly died, 2 of them sadly died. So I'm just there's any genetic predisposition to this disease, perhaps?
I think, to be honest with you, and as I said earlier, we took very, very good precautions in terms of our staff and healthcare workers in terms of PPEs, as well as limiting certain measures or treatment modalities like the BiPAP, the high flow oxygen, which will increase the risk of exposure to the staff. I know in the UK, they use BiPAP a lot. And I don't know if that's one of the reasons why a lot of their staff got exposed to aerosolization. If there is cartoons of showing patients on BiPAP with all the aerosolized air with viruses, it's like a cloud raining viruses. And if anyone is there, probably they will be at high risk. Now you have to be with the patient for a good 10-15 minutes to get it. And I bet a lot of these healthcare workers who got infected got exposed for that long time.
مشكورين جدا.
I also, sorry, this is Anwar. I'm obviously not a doctor, but I do study race. And I will say some of the other factors involved in this are, first of all, pre-existing conditions are higher among low-income communities and especially communities of color. And those are obviously risk factors here. And also, low-income jobs are more likely to be essential jobs, essential workers. And so a lot of people of color, particularly Black and Hispanic people, are going out for their jobs at rates that wealthier white people are not, and that exposes them to the virus differently too.
أعتقد نقدر نلخصه. بارك الله فيك دكتور محمد، بارك الله فيك دكتور يوسف، دكتور محي الدين، شكرا للحضور جميعا. حاولنا ناخذ كل الأسئلة اللي موجودة. ما زال على الموقع متاع التحالف حيكون الفيديو، حيكون أي أسئلة عندكم تقدروا تفضلوا بها. هذا طبعا دافع ان احنا نديروا ريسيرش. ليش في ليبيا مثلا الحالات اقل؟ لو كان في ناس انترستد ويقدروا يتساعدوا. دكتور خالد اللي متحمس جدا، هو مش موجود معنا توا تقريبا، طلع متحمس جدا لهذا الموضوع. لو كان في ناس تقدر تدير ريسيرش لماذا في ليبيا الحالات أقل، هل لها علاقة بالقفل الكامل ما فيش انفلوكس للحالات، هل لها علاقة بالجينز، هل لها علاقة بدرجة الحرارة، مش معروف. كذلك غدا لما يبدو في ناس عالقين مروحين شو ممكن يتغير، هل ممكن في سترينز جديدة تخش للبلاد، فيروسز. هذه معلومات مهمة جدا، لو كان في ناس انترستد في هذا الموضوع ممكن نتعاونوا مع بعض. ممكن الدكتور خالد هديلي كذلك يتعاون معكم وهو مرحب بهذه الفكرة. نشكركم جميعا. لو كان في أي حد عنده إضافة كان هذا خنديره كونكلوجن نسكره. أي حد عنده إضافة؟
لو زي ما قال الدكتور خالد احنا حنبعتوا لكم ايميل ان شاء الله بالرابط لليوتيوب والموقع بتاعنا حيكون عليه الفيديوز من اليومين ان شاء الله. ولو في اسئله بشكل عام او حتى لو عندكم يعني افكار لبرامج ممكن تفيدكم كدكاتره في ليبيا في مواجهه كوفيد، لو سمحتوا تواصلوا معنا، نبعت ايميلنا في التحالف في الشات ان شاء الله.
شكرا جزيلا لك أنوار. أنت كنت بارك الله فيك العمود الفقري لكل هذا اللي يحدث. شكرا جزيلا لكم جميعا دكاترة على وقتكم، ونلتقي على خير إن شاء الله.
صحيح. خلونا نشوفوكم يا شباب. محمد تركي خلينا نشوفوك.
ان شاء الله ان شاء الله وانت طيب. يلا كل عام وانتم بخير.
وين
بارك الله
غايب؟
فيك يا خالد العاقل.
شكرا جزيلا
على
لكم.
المجهود.
شكرا جزيلا لكم. كل سنة وانتم طيبين. نلتقي على خير عن قريب ان شاء الله في برامج.
السلام عليكم.
عادل تشورك ما زلت قاعد ولا طلعت؟ عادل
كيف طلع؟
اوكي.
يا ريت تتواصل مع دكتور يحيى، هو دكتور عادل عنده عتب علينا لان الباين ما وصلاش ايميل امس، فانا حاولت.
لا عادل دزيت لنا الفلاير يا خالد.
انا اعتذرت له طبعا وقلت له انت حتلقى كل شيء على الصفحه نتاع التحالف.
ايوه بس على فكره يعني that's why I try to get in touch with them، لان كيف ما قلت لك انا will encourage everyone، عرفت ان كل واحد يحط لا افضل صح، كل واحد forward الفلايرز لمعارفه، عرفت؟
نعم.
لان عادل that's how I did it امبارح. I know I don't think that we have enough advertising، يعني الويب سايت مش كل واحد يخش على الويب سايت ومش كل واحد عارف الويب سايت، عرفت؟
هذا ثاني لقاء ان شاء الله، حيكون في لقاءات اخرى ان شاء الله في الاسابيع القادمه.
اوكي باذن الله. لا ان شاء الله. الحمد لله was very successful والله ما شاء الله. ومحمد تركي did a wonderful job. I was very impressed.
يعني احنا we had around 30 probably اليوم وامس، لكن the total of the people 30 each day قصدي, but the total of the people who signed up is actually around 100.
Yes,
so
yeah.
We did reach a lot of people, alhamdulillah.
But here, once we get out of Ramadan, inshallah, I think will be a good time, عرفتي? And I believe either Thursday night or Friday might be a good day to do it.